Hi again. We are going to be in chapter 10 today. This chapter is super short, however, it is packed with lots of great topics. So I'll just be walking you guys through some of these important concepts today. This chapter is all about the care of women with complications after birth. I think everybody would like to believe that pregnancy and delivery is normal and that nobody ever has any problems, although we know that's not the case because that's why I have a job. Unfortunately, things do go wrong. Unfortunately, problems do arise, and that's why I feel it's so important for women to deliver in a hospital, because unfortunately, a lot of these situations can't be predicted. They just happen. So we're going to talk a little bit about these different situations today. So first off, the categories of postpartum complications include shock, hemorrhage, thromboembolic disorders, puerperal infections, subinvolution of the uterus, and mood disorders. So we're going to talk in a little bit more detail about all of these. First off with shock, that is a condition defined as a failure of the cardiovascular system to provide essential oxygen and nutrients to the cells. Now, this can come in different forms. You can have cardiogenic shock, hypovolemic shock, anaphylactic shock, and septic shock. And it's all of them have their own caveats as far as what clinical manifestations you'll see to diagnose them, but shock in and of itself is important to be treated quickly and thoroughly so that we can avoid maternal death. With hemorrhage or hypovolemic shock, you can have either an early hemorrhage or a late hemorrhage. An early hemorrhage occurs within the first 24 hours of the postpartum period. A late hemorrhage can occur between 24 hours and 6 weeks postpartum. So it's important that when we discharge our patients after they deliver, that we educate them on signs and symptoms of a late hemorrhage, because they can happen even when they go home. Obviously, the major risk is hypovolemic shock, because that decreases the amount of blood that is circulating, which decreases the amount of oxygen that the cells get to function. So it's really important that we have enough blood circulating, carrying enough oxygen to our cells, and also removing those waste products from our cells so that they don't back up in our system and cause acidosis. So really important that we try to avoid that. And that works really well when our systems are functioning properly and there's no problems. However, when our patients lose a lot of blood, that's when this can become a problem. So some signs and symptoms of hemorrhage. The very first sign that you're going to see might be a little bit different than your average med-surg patient. I think most of us tend to think of hemorrhage, you think of blood pressure decreasing right away. However, in healthy women who've just given birth, the first sign that you'll see is tachycardia. So be very suspicious if you have a pulse rate greater than 100 in a normal, healthy young woman. Eventually, the blood pressure will fall. You might notice pale, cold, and clammy skin, and that's happening because as the body is losing blood, it's communicating. The brain is in charge of everything, and the brain is sensing that there's not enough blood circulating, not enough oxygen circulating. And so what it does is it's going to spare its vital organs. The vital organs are the brain, the heart, and the adrenal glands. And so what the body does is it says, uh-oh, I feel like I don't have enough oxygen. So what I'm going to do, I'm going to pull blood away from all my non-essential organs, and I'm going to shunt it to my most essential organs. And so what happens is blood gets shunted away from those non-essential organs, and the periphery, the hands, feet, everything like that, kidneys, liver, are all non-essential. And so as blood gets diverted away from those non-essential organs and it gets shunted to its most vital organs, the hands and skin will become cold and clammy because they're not getting normal blood flow. Eventually, you might see a change in mental status. That would be a very late sign, so hopefully you are intervening well before that happens. And then eventually, because the kidneys aren't an essential organ and blood is being shunted away from them, you will see a decreased amount of urinary output. So hypovolemic shock occurs when the volume of blood is depleted and cannot fill the circulatory system. And if it's not corrected quickly, death will ensue. So that is the goal. We want to avoid that. So what do? We replace the lost blood volume. That's how we fix her. So initially you'll see, like we said, tachycardia and maybe some tachypnea as the body tries to compensate. So initially it senses that there's not enough oxygen getting to the cells because there's a decreased amount of volume in the blood. And so the heart increases its rate and it says, okay, well, maybe I'll just pump a little faster and that will get the oxygen needed to my cells. And in order to take in the most amount of oxygen, she increases her respiratory rate as well. So this trying to get the maximum amount of oxygen in and the maximum amount of oxygen pumped around to the cells of the remaining blood. Eventually, the blood pressure shows a narrow pulse pressure, which is a falling systolic value and a rising diastolic value. Blood, like I said, will eventually move away from the non-essential organs, and that leaves things like the skin, mucous membranes, pale, cold, and clammy. So what do? We want to stop that blood loss. Wherever it's coming from, we want to stop it if we can. Initially, we'll give just any kind of volume to replace or to help increase the amount of volume circulating. So even if it's just IV fluid, we can do that initially until we can get blood products at the bedside. Unfortunately, it does take a little bit of time to get blood products, but during an acute hemorrhage situation, our blood banks, our labs, they know that when we request a massive transfusion, they kind of drop everything and they give us everything that we need immediately. So it becomes kind of like a trauma situation. So think of your ERs, and when they get a patient who's involved in a trauma, who's lost a lot of blood, the lab goes on hyper mode and gets lots of blood to the ER. Well, it's the same kind of situation in OB. When we have a hemorrhage happening, the lab gets us everything that we need right away, and we know that we can work together really well and really effectively to get what we need, because we know the only way to really save her life is to replace that blood volume with blood and other blood products. So we will give packed red blood cells, and we give those in a ratio that the lab determines that will keep her system balanced. So we also give plasma and platelets as well to keep everything balanced. We will also give her oxygen so that we can maximize the amount of oxygen that she's taking in. And then eventually we'll need to place a Foley catheter so that we can assess her urine output and hopefully preserve her kidneys so that no damage happens. But that's one way that we can tell if her kidneys have been damaged by the low amount of blood flow that they've been getting. Our nursing care is going to involve very frequent vital signs, measuring oxygenation levels via pulse ox, measuring lochia. So if she's hemorrhaging from like Atony, from a boggy uterus, we want to make sure that we are weighing chucks and pads, anything that's collecting blood. We want to measure that so that we can keep an accurate assessment of how much she's lost. We'll continue assessing the fundus. So if that is the problem, we want to see whether or not what we're doing for her is helping that get better. We'll do accurate I's and O's, monitor frequent CBCs for anemia to see if her hemoglobin level is increasing or decreasing. And then remembering that we also need to provide support to her and her family. This is a very scary time. These situations, they tend to happen quickly, and sometimes the patient can be forgotten in the midst of trying to save her life. But we do need to make sure that we're explaining what we're doing, why we're doing it. It may be that we need to escort her family out of the room just in order to clear paths and make way for additional assistance from different people. But we definitely want to keep their family members in the loop because, again, it's a very scary situation. So again, just pay close attention to that heart rate and be very suspicious of either hypovolemic shock or infection if you get a heart rate that's greater than 100. That is just not normal in a healthy young woman. So you know that anemia occurs due to the loss of erythrocytes. A lot of our patients will usually start off by complaining of dizziness or being lightheaded, and they may be supplemented with iron for several weeks postpartum until those levels can get back to normal. So an early postpartum hemorrhage is usually caused by either atony, lacerations or tears of the reproductive tract, or hematomas in the reproductive tract. And I put this picture here on the left so you can see how that uterus can fill up very easily with blood. That's usually caused by atony. So atony is when that uterus fails to contract and those blood vessels where that placenta was attached continue to just bleed and bleed and bleed, and all that blood collects in the uterus, which prevents it from contracting anymore. And that can lead to a very severe hemorrhage, kind of like the picture on the right. So again, uterine atony is when blood collects in that uterus and those muscle fibers are flaccid. They're not contracting, and so they're not ligating those vessels. If you remember from last week, I showed you how when that uterus contracts, it kind of ligates those vessels and it prevents those vessels from continuing to ooze and bleed. And that is that as that uterus contracts, it's shrinking down, and we want to make sure that that blood gets expressed out so that that uterus can clamp down even more and stay nice and contracted. When it fills up with blood like this, it can get over distended, and it prevents further contracting. Also, causes of uterine atony can be retained placental fragments. So if there's any retained products of conception still in the uterus that didn't come out at delivery, the uterus, as a way of kind of cleansing itself and flushing out those pieces, it will kind of force itself to bleed, to kind of wash itself out. But sometimes those products are still attached to the uterine wall, and so what happens is the uterus just continues to bleed and bleed and bleed, and it fills up with blood, and then it can't contract, and you see how the problem just kind of goes in a vicious cycle. Some characteristics of uterine atony, definitely the most common term is going to be a boggy uterus. So we use that term boggy, meaning that it's not contracted. It's not nice and firm like it should be. It's soft. And we need to kind of massage it to get it to try to firm up and get all that blood out of it so that it can contract better. Typically, you'll find that the fundal height will be above the umbilicus. That's a sign that that uterus is not well contracted. You may see that lochia is in large amounts or even large clots. And so you just kind of have to do very frequent assessments. That's why after she delivers, we do fundal assessments and vital signs every 15 minutes for the first hour, so that hopefully we can pick up on any signs of atony or boggy uterus or hemorrhage. Lacerations can also cause a hemorrhage. So we want to make sure that we're inspecting the perineum for any signs of trauma or anything that needs to be repaired. Remember that the vasculature in this area is very engorged from the hormonal effects of pregnancy and delivery. One of the characteristic signs of lacerations versus just bleeding from inside the uterus is going to be the color of blood. Usually the blood that's coming out of the uterus due to like atony or boggy uterus is going to be a lot darker than the blood of like a laceration. Blood from a laceration is it's much more bright than the blood flow from the uterus, and it usually flows in a continuous trickle, Whereas if it's due to a boggy uterus and uterine atony, you'll just get big gushes of blood versus a constant trickle. So that's kind of a way you can see the difference and kind of try to figure out where this extra bleeding is coming from, is that color of blood and how it characteristically comes out, whether it's that trickle or it's a gush. So typically when you're doing your fundal assessments, the uterus will palpate very firm. It'll feel very contracted. And so that's one of the signs that it's not related to uterine atony, it's something else. And so then we immediately start to think of lacerations. Now, lacerations can be anywhere. They can be on the perineum, they can be in the vagina, they can be on the cervix, they can be around the urethra. So it just kind of depends, and it's up to the provider to kind of inspect that area and figure out where those lacerations are and if they need to be repaired. Treatment is usually going to be sutures, but not always. Sometimes they're small enough to where they can just kind of hold pressure and they'll just kind of heal naturally on their own. But most of the time, a laceration that's continuing to bleed will need some type of suture. As nurses, we'll keep her NPO until we are confident that the bleeding has stopped and that there's no threat of going to the OR. Hematomas can also form in the reproductive tract, and this is a collection of blood within the tissue. So blood continues to build up behind the skin and the tissue, and it looks kind of like a bruise, and eventually it can bulge out. These are very commonly seen on the vulva or inside the vagina, looking very bluish and purplish in color. Usually the patients will complain of a severe amount of pain, more so than what's normal. So normal people after delivery are maybe a little uncomfortable, but the pain of a hematoma is going to be much more significant. They may complain of pressure in the vulva area, in the pelvis, or even the rectum. And they typically will not have usual amounts of lochia because it's being, it's all going into the tissue. So be suspect of a hematoma developing if you have an unusually small amount of blood flow. Now, late postpartum hemorrhage is usually caused by retention of placental fragments or subinvolution of the uterus. So we need to make sure that she is well educated going home of the signs and symptoms she needs to report to her provider. And that would include persistent bright red bleeding or return of bright red bleeding after it is changed to pink or white. So if it seems like it's getting less and then all of a sudden it picks up, that's definitely something to report to her provider. Also, saturating more than 1 pad an hour is something she needs to report to her provider immediately. When she returns back to either the clinic or the hospital, you'll probably need to start an IV and consider possible surgical intervention for something like a DNC if they are suspecting placental fragments being left behind. Subinvolution of the uterus is a slower than expected or a failure of the uterus to return to its normal pre-pregnant condition. So remember we said normally that uterus contracts, and as it contracts over the next few days, it's shrinking back to its normal pre-pregnancy size, and that usually happens at the descent of about 1 centimeter per day. Now, sometimes that doesn't happen according to that rate, and so we call that subinvolution of the uterus. And some signs and symptoms of that would be a fundal height greater than expected, the persistence of lochia rubra, pelvic pain and heaviness, and fatigue. So our nursing care with women with subinvolution of the uterus is we want to teach them what's normal so that they can report anything that's not normal. Abnormal things would be like fever, pain, persistent red lochia, or foul-smelling discharge. Again, these women may be taken to the operating room for surgical interventions, or they may be given medication. So it just kind of depends on the severity of the situation and the provider's discretion. So now we're going to switch gears and talk about thromboembolic disorders. This is where a blood clot develops and can break off and travel to the lungs, the brain, the heart. So we want to avoid that, obviously. If you remember way back the first couple weeks of class, we talked about how pregnant women are hypercoagulable, and that's good when it comes time to delivery because we don't want them to bleed too much. However, we don't want them to have such high clotting factors that they develop clots. So it's kind of that fine line of what's good and when it can cross that line to being bad. Sometimes what we do to our patients can make them more prone to a clot formation, such as when we put their legs up in stirrups and maybe they're pushing for a long period of time, or maybe they're having a pretty lengthy repair to their perineum after delivery. It can cause stasis in those lower extremities and a clot can form there. There's different types of thromboembolic disorders. There can be a superficial vein thrombosis, a deep vein thrombosis, and then there could be that pulmonary embolism when that clot breaks off and travels to their lungs. So signs of a pulmonary embolus are going to be dyspnea, coughing, and chest pain. So we want to take any of those symptoms very seriously and investigate it until we can prove that she absolutely does not have a PE. So we always assume worst case scenario and work back from there. We want to teach our patients not to cross their legs or not to stay in one position for too long. So we want them to get up, move around frequently, avoid pressure behind the popliteal space, and just encourage early ambulation, range of motion exercises. If they are going to be on any type of bed rest for a period of time, we might want to think about SCDs or anti-embolytic stockings. Sometimes women will be given anticoagulant therapy, and of course we'll want to educate our patients on the danger signs of too much, so prolonged bleeding with minor injuries, nosebleeds, or unexplained bruising. We need to caution them to use a soft bristle toothbrush so their gums don't bleed. And we want to make sure that they understand the follow-up care involved with serial lab screens so that we can make sure that the dosage is correct for them. And remember, the antidote would be vitamin K. We're going to switch gears now and talk about infection or sepsis. So sepsis is an infection that occurs after childbirth, usually characterized by a fever of greater than 100.4 or 38 degrees Celsius in the first 24 hours for up to 2 days, up 2 to 10 days postpartum. Some risk factors that predispose them to developing sepsis could be cracks in the nipples of the breast, a surgical incision, trauma to the tissue during labor, so those lacerations, the open wound at the placental site in their uterus, retained placental fragments or blood clots, an increase in the pH of the vagina after birth, and endometritis, which is an inflammation of the lining of the uterus. There's lots of ways people can develop sepsis. The dangers of a septic infection is that it can ascend quickly. So it may start in like the perineum or the vaginal area, the cervix, and then it can just ascend up into the uterus, the fallopian tubes, peritoneum, can cause peritonitis, which we know is a life-threatening condition. So there's lots of ways that a woman can develop sepsis. Again, hand hygiene is going to be the best way to prevent this from happening in our patients, and we want to encourage our patients to use good hand hygiene as well so that we can avoid the spread of those infectious organisms. I'm sure you are already very good at wearing your gloves anytime you're going to be in contact with any blood or bodily fluids, so that will help protect our patients as well. As far as educating our patients in good nursing care to prevent septic infections, again, good hand hygiene, promoting adequate rest and nutrition will help healing. We'll teach them to observe for signs of infection. We'll teach them how to use good perineal hygiene as well. So making sure that they know to wipe from front to back, making sure that they change their pads frequently, that they empty their bladder frequently, all those things And if they are prescribed any antimicrobial medications, they take those as prescribed, making sure to complete the course of therapy, not stopping it once they feel better. And I'm sure you guys already know those are common instructions when patients are taking antibiotics. Mastitis is an infection of the breast. Some signs and symptoms can be redness and heat in the breast, tenderness, edema or heaviness of the breast. Purulent drainage may or may not be present. Most of the time, patients will have signs and symptoms of infection, which include things like fever, chills, and other systemic signs of infection. And occasionally, you might see an abscess that's formed. So you want to educate your patients to make sure that if they have any of these symptoms, that they are contacting their provider very quickly so that we can treat this quickly. Usually antibiotics will be prescribed, and again, we'll want to make sure that they understand that they have to complete the entire course of antibiotics, not stopping them once they start to feel better. Sometimes mild analgesics can be prescribed as well for discomfort. We do want to encourage them to breastfeed, especially with the unaffected breast, and as much as they can tolerate with the affected breast. We want to avoid the breast filling up with too much milk, so continuing to pump, and even if they needed to discard the milk from the breast, can help relieve some of that discomfort. Heat will promote blood flow to the area, so that can be helpful. Massage of the area will improve milk flow and reduce stasis. You want to make sure that that you encourage fluid intake so that that helps kind of flush the milk through. Wearing a supportive bra will help provide some support, and just providing emotional support to the woman. Keep in mind that a lot of times mastitis develops within the first few weeks of having a baby, and that's usually a time when they're very fatigued. They're probably overwhelmed. They may or may not have other children that they're trying to care for in addition to a baby. They're probably not getting much sleep. And so you throw an infection on top of everything that's already going on, they're probably going to need a little bit more support than the average person. So just keep that in mind and provide that as needed. Next, we're going to jump into mood disorders, and we talked about this a little bit last week. We kind of introduced the idea, so we're just going to kind of refresh on what we talked about last week and kind of expand upon it this week. So mood is a pervasive and sustained emotion that can color one's view of life. And we know that it's normal to have the baby blues or the postpartum blues after birth, and we know that that is transient. It lasts for a short period of time, and it usually corrects without any real treatment. So it's characterized by having periods where she feels kind of let down, overwhelmed, and usually it will kind of dissipate as she adjusts to her new role as a mom. Postpartum depression, we said last week, is kind of the baby blues extending for a longer period of time. It can usually manifest within the first 4 weeks after delivery. It is an impairment of her perception of reality, more serious than just postpartum blues. It can interfere with her ability to respond to her baby's cues, and it can affect her bonding with her baby as well. So this is something that we definitely want our patients to know about. We want to talk about it openly. We don't want there to be any judgment or bias, but we want to make sure that they understand that they need to contact their provider if their baby blues or depression is kind of progressing more than just that first 2-week period. Risk factors that make somebody a little bit more susceptible to postpartum depression include her lack of support, maybe a poor relationship with the partner, life and childcare stresses. You probably can imagine right now, given the situation of the world, that there's a lot of extra stress during this period when somebody is having a baby. And so that can make somebody a little bit more predisposed to postpartum depression. Low self-esteem, being an unplanned pregnancy can also predispose them to postpartum depression as well. So it's just all about and maybe how they planned and prepared and the kind of their current mental state. I'll add some of these videos to Moodle for you guys so you can take a look at those. It just kind of helps you understand what somebody feels like when they experience postpartum depression, and also postpartum psychosis, which we'll talk about here in just a second. So some signs and symptoms of postpartum depression include lack of enjoyment in life, lack of interest in others, intense feelings of inadequacy, unworthiness, and guilt, an inability to cope, a loss of mental concentration or an inability to make decisions, disturbed sleep or appetite, and constant fatigue and feelings of ill health can also be signs and symptoms. So again, we want to make sure that these women are communicating with their providers and getting the help that they need. As nurses, you might be that first person that they come in contact with before they even speak to their provider, and so we need to be sympathetic and a good listener. We want to encourage them with open-ended questions to talk about their feelings. We want to observe for complaints of sleeplessness or chronic fatigue, provide some support where we can, help her identify her support system and maybe some other areas that she hasn't thought about that could help her get through this. Trying to determine if she's getting some exercise, an appropriate amount of sleep and nutrition. We might need to help her identify ways to meet her own needs and refer to support groups if we have those available. Now, postpartum psychosis is a much more extreme condition. It's something that you kind of only hear about when things go really bad. So in the news, you hear about the mothers who either took their own lives or their children's lives. So that is what we're talking about with postpartum psychosis. It's a very extreme state, and it's more common in patients who've had prior mental health conditions such as bipolar, major depressive episodes, or other types, maybe schizophrenia. And so we need those patients need to be high on our radar for high risk of postpartum psychosis, but it can occur also in other women who have never had a history of mental illness. So again, no judgment, no bias, having an open mind, and just really trying to offer the help that she is going to need immediately. Like I said, I'll put these videos on Moodle, so it'll kind of help you guys understand what it's like for some people who have experienced postpartum psychosis. And of course, the goal would be keeping both the mom and the infant safe. These women, most of the time, do need hospitalization, and usually will include some type of medication as well. Unfortunately, a lot of these medications are not safe for them to continue to breastfeed. However, we do recommend that they continue pumping. They can just dump their milk temporarily until they're no longer on these medications. But they can still continue breastfeeding after they finish those medications. So again, take a look at these videos. I think that'll really kind of help you guys wrap your brain around the difference between postpartum depression and postpartum psychosis. Just one more little piece of information here on homelessness. Unfortunately, that continues to be a problem even here in this area. Oftentimes, women may not necessarily live on the street per se, but they don't have a permanent home. And so they might live with various people, they might live out of their car, they might live in a hotel room, but that makes them at high risk for not getting the care that they need. It's difficult to follow up with these patients, and so before we turn them loose and discharge them, we want to make sure that as much as we can that they have a safe place, and that we have some way to follow up with them so that if they need our help and other services, that we are available to them to help with that. There are lots of programs out there to support women like that in the community, and so hopefully we can get that information to them before they leave our care. So that concludes this lecture for chapter 10. I told you it was going to be very short, but it's packed full of lots of really important things to think about. So hopefully you guys enjoyed that, and I will talk to you again.